All right. For this week's slides, we're going to talk a little bit about the marketplace, direct primary care, and employer-based plans. So we've gotten the opportunity to talk a little bit about the ACA, how that directs people into either Medicaid plans based on income or employer-based plans for people who are eligible to have them, which is only about 40% of our workforce, or to the marketplace or the exchange. So the activity that you guys are actually doing this week and submitting as your week 6 assignment is for you to actually have a little bit of experience with the marketplace. So for those of you who have employer-based plans and or are covered by parents and or are covered by Medicaid, you might not have had the opportunity to actually go through the marketplace and figure out what it looks like to buy a plan on there. If it feels buggy or confusing or cumbersome, welcome to the world of the marketplace. That is what it is for a lot of people. Imagine going through that process with needing all like social security numbers, income details, all of that on board too. So there's definitely a lot of documentation that goes into it when you're going just from browsing to actually applying. The online application can actually take hours to fill out depending on how much information, how many dependents you have and all that that you actually have to supply. So let's talk a little bit about the marketplace to just understand what happens and what happened as a result of the ACA to create this middle ground called our marketplace and to capture the uninsured people. So to wrap up, or to wrap it up a little bit, one of the determinations is age. So if you are under 26 and able to be covered under a parent or guardian, you wouldn't necessarily end up in the marketplace. If you're a child, you are likely to be covered under Medicaid and or the CHIP program. And if you're 65 and over, then you have Medicare. So this is really to capture the people who aren't covered by a certain age group, depending on whether there's prior coverage there or achieving retirement age. Location. So the other thing that you have to input in there, and you'll see from the scenarios, is where you live. So there are different plans and different tiers of plans available depending on where you live. So what we have available on this side of the mountains is really different than what people have on the other side of the mountains. It varies pretty distinctly if you're down in Chehalis or up in Skagit, and it differs very greatly to what other states also offer. So what you're getting an experience with this particular writing assignment and doing the activity is what the Washington State marketplace looks like. And what you're dealing with in that activity is far more sophisticated than what a lot of states have actually managed to put together. Tobacco is another thing you input. So related to that concept of risk management or underwriting, although we are not allowed to do things that then get into the realm of pre-existing conditions, one of the things that is still allowed to be input as a potential risk factor, but ultimately calculating a different premium, is your tobacco use. So your premiums can go up by as much as 50% more if you claim that you are a user, even infrequently, of tobacco products. So that includes whether you chew it, whether you smoke it, whether you vape it, any of it. The other thing to keep in mind is that insurance companies, whether they are employer-based, whether they are Medicaid, or whether they are, private insurers that you contract with through the marketplace, may request your health records at any time, which they do frequently. We send out records to insurers all the time, and what they're doing is an audit to make sure that the things that people fill out in their paperwork are actually true. So if people document that they are not tobacco users, but it is ever documented in their medical record at any time that they've used tobacco, they can lose their coverage, at the very least with that insurer, and possibly permanently. The other thing that you also have to document is, are you filing for an individual, family, dependents, and then the plan category. So, I didn't mean to flip forward. The plan category, as you'll see when you guys do the assignment, that's that bronze, silver, gold, platinum. And ultimately what happens, and it's hard to do this in a video format, but I normally get to do my little demonstration in person, is that essentially if you pay a lower premium, so that's like your gym membership fee, then you will have a higher deductible. Meaning, so the analogy I like to use is like, this is like golf club membership. So at least around golf clubs around here, you have to pay a certain membership fee every year to be a member of the golf club. You also, as a requirement of being a member, and this is above and beyond your membership, have to spend a certain amount of money in a cafe. The golf club membership is like your premium, and the cafe spending is like your deductible. So if you pay your membership, your premium, that's just to have coverage. That's just to have your ticket to walk in the door. Your deductible is another amount of money that you need to spend or meet to satisfy the requirements, the contractual agreement between you and the insurance company, so that they will continue to pay on your behalf. Or in the golf club analogy, you can, then have, I don't know, free services at the golf club. You've met your contractual obligation. Or I think of it as maybe like a co-op preschool. You pay the fee every month, but you also still have to do 60 hours of volunteer time, or you can buy them out. That's kind of like your deductible, the buyout or the volunteer time, and the monthly fee is like your premium. So you'll see from the different tiers that the bronze plans overall have lower, off-the-cuff costs, like your premium is a lot lower, but your deductible is higher. The gold and platinum plans are going to have much higher premiums, but lower deductibles. And really, when you total it up, if you were to exhaust your deductible and pay all your premium, most of these plans have people spending anywhere from $7,000 to $10,000 in a year, if they use them fully. Now that's really the key when you're talking about shopping on the marketplace, in a way that you don't have to do when you have employer-based plans. They usually just offer you one. Maybe you have the choice to choose between Kaiser and Regents or something like that. But generally speaking, you don't even have choices in an employer-based plan. And in Medicaid plans, there are no copays, coinsurance, deductibles, all of that. So really, you're just choosing the plan that maybe your provider takes or that is even available in your area. So the marketplace also makes this a lot more complicated for people, because not only are all these other factors, age, location, sex, tobacco, family dependence, all that figured into your premium, but also you kind of have to be able to calculate how much am I going to spend this year on healthcare. For someone who is quote unquote relatively healthy, by the ways that we typically define them, meaning low healthcare utilization, doesn't always mean they're healthy, it just means that they use healthcare less. They might decide, well, I only go to the doctor once a year. I get a couple labs. I don't take any medications, so I'm going to pay the lower premium and go for the higher deductible. So at least I have coverage if something bad happens. It might not, my out-of-pocket max might still be like $15,000, but at least I know my monthly costs are less, and I can manage those. On the flip side, for other people, they might say, you know what, I don't want any surprises if I end up in a situation. That's exactly the situation. I don't want to find any hidden costs or to walk out of a hospital with a $15,000, $20,000 bill or a, even higher bill. So I'd rather pay the $500 premium to make sure that all I have is like maybe a $500 or $1,000 deductible. Maybe I get a couple office visits, I knock that out. And then I know that after that, everything's covered. So if something does happen, I don't have to worry about it. Those are both kind of the what if situation. How would you plan for that, and what plan would you buy? The other situation is, do you actually have chronic health conditions? Do you have something that you are managing where you need to be seen every month or every quarter? Do you have ongoing care like PT, rehabilitation from a surgery or an injury? Are you managing mental health concerns that actually require being followed by a psychiatrist or psych-ARNP and a mental health counselor much more regularly? In which case, you can pretty much anticipate that you're going to be knocking the ball out of the park with your healthcare costs that year. And that you might actually want to be able to plan for it a little better and say, you know what, I'll take the highest premium that's possible with either a tiny, tiny, tiny or no deductible, and at least be able to say, like, look, I spent my $600 a month on my premium up front, and I know I spent all I'm going to have to spend that year, and I'm not going to have any surprises in the end. It kind of helps people plan. Now, this is if we have the funds for planning. For people who don't have the ability to even think about buying a $600 a month plan, and really the only one they can consider is the $250, well, decision made. This is just to talk about a little bit about pre-existing conditions and why this was such an important part of the ACA, if anything, probably why it stood out the most and why it's so critical to the marketplace. So, before your options were always Medicaid, Medicare, and employer-based plans. But two of the major things, lots of things that the ACA did, one was to provide this option of the marketplace, but a subsidized version. So even though people have a lot of complaints about how much these exchange plans cost, if a person who did not have insurance with their employer or did not meet income requirements for Medicaid wanted to go buy a plan, you could call up Regence and Premera and say, hey, give me a plan, but that might have been $1,500. Now you have the ability, even as an expensive gold or platinum plan, to buy a $600 plan. So part of that is what we talked about a few weeks ago, where essentially it was a deal with the insurance companies. Hey, look, you're going to have to include pre-existing conditions. They're going to cost you more money, and you're going to have to lower the prices, but we're going to get you more people buying your plans. So, lower the price, cost of goods, or the cost of sale, and you get more people in the door. For the most part, that worked out. In fact, it worked out quite nicely. So insurance companies actually didn't end up losing a lot of money, even with covering pre-existing conditions and our tax penalties subsidizing the cost of these plans in addition to them regulating the prices. So that's partly how the marketplace was also made possible. But also why it was really necessary was to capture all these people who were uninsured and or because of pre-existing conditions. So a little bit more related to the constitutionality and what we talked about before, and how really the marketplace, despite, this is kind of where a lot of the contention is happening. So despite what it's trying to do and capture uninsured people, specifically really to capture those like millions of people with pre-existing conditions, and to capture people who are, at least mildly more incentivized to buy insurance now that it's mildly more expensive. It's also the seat of a lot of contention related to the constitutionality argument, as we talked about, related to commerce and tax laws and all of that. Contrast this a little bit to employer-based plans. So we talked a little bit about the history of this. This is like week 2. If you want to refresh on ACA and history, the week 2 videos that I made go over all that kind of stuff. So this is kind of how employer-based plans even became a thing. The Stabilization Act and Baylor's kind of little pilot project back in the 20s. But what's interesting is that a lot of other countries don't do this way. A lot of other countries who, primarily have socialized or what we call universal health care, they have employer-based plans, but they are on top of what the country already covers for baseline health care. They don't rely on employers to provide baseline health care. So to say that a different way, and I think that this is a really important mindset cultural shift, as countries do not make employers responsible for providing health care and minding the well-being of the people in the country. Or another way to say that is they're already taking care of the basic needs of people in their country, and employers are offering supplemental health plans, like what happens in BC, where they have social medicine. Everyone there has preventive and emergency care, but things like PT and dentistry are not covered. So employer-based plans in BC will look like plans that offer dental care, or physical therapy, acupuncture, chiropractic, massage therapy, kind of the other physical modalities that people might not have access to through social medicine. Versus the way that our employer-based plans, where it's like even your access to preventive care and emergency care comes through the gatekeeper of your employer. So it's just an interesting mindset shift, wrap your brains around that, because I think it's really fascinating in terms of the fact that 40% or more at this point of people in this country think that employer-based plans are kind of like the gold standard. Like, yeah, when you get a job with benefits, you've made it. And it's interesting that we think we've made it when we're expecting our employers to look out for us. So a little bit more about employer plans and deductibles and how they've shifted over the years. Employer-based plans were also partly like, gold standard, the thing to get because they also typically had very low deductibles. But we're also seeing now in post-ACA data is that, 81% of them also have deductibles. Now their deductibles might be slightly less than what you guys are seeing in the marketplace activity, where you're seeing $1,000, $3,000, $5,000 deductibles. Most employer-based deductibles are $1,000 and under. Like I'll speak for the University of Washington, most of their plans offer $250 deductibles, which is, pretty insane for a self-employed person who's always had a $10,000 deductible. So thinking a little bit more about employer-based plans, how much of their employees actually incur healthcare spending. So think about this again, a little bit of a mindset thing. 50% of employees incur 3.5% of healthcare spending. So really, employer-based plans, although they cover 40% of our country are employer-based plans, or not, yeah. And 50% of those people, so effectively 20% of people, are incurring 3.5% of healthcare spending. So it makes sense. Okay, fine. There's at least like a good 80% that encompasses the other 97% of healthcare spending. But that we don't really capture a lot of our healthcare dollars or the way that we spend our dollars with employer-based plans. The people who are quote unquote costing the system more money are not people who have employer-based plans. So think about how all the social dimensions of health start to overlap here in terms of education and access to jobs and food and, geography and access, health behaviors and access to healthcare. And they all kind of layer up here in this way where you tend to see people who qualify for jobs that have employer-based plans also tend to fall into categories that spend less money and spend less healthcare dollars overall. So employer-based plans, although they provide a lot of healthcare in this country, 40% of the people, they don't actually capture a lot of the way our healthcare dollars are spent. One of the concepts I want to bring up for you guys is the concept of direct primary care. So people are trying, if healthcare, if everything that I've introduced to you, I certainly don't expect any of you to be experts or really even fully understand all of this. It is incredibly complex stuff. There are people who have spent decades on this, and we are still with the system that we have. So, if it feels cumbersome, it's because it is. But people are really trying to reinvent how we deliver healthcare. Because the way that it is delivered involves these middle people, insurance companies. It creates a lot of distress, financial and otherwise, for people who don't have access to employer-based plans. Or Medicaid, except that to access Medicaid, you have to be in a certain amount of financial distress. So pretty much 60% of the country who doesn't have employer-based plans is living in some sort of financial and or lifestyle and or, other dimensions of health and life distress or stress that makes the delivery of care or their ability to access care more challenging. So people are looking for other ways to figure out how can we spend healthcare dollars more wisely? One of the thoughts is take the middle person out of it. Get rid of insurance companies altogether. Have the country provide catastrophic emergency care. You broke your arm, you're in a car accident, go to the hospital. The hospitals are funded. You're good. Everything else is paid for out of pocket, potentially through a concept of direct primary care. This is obviously not taken off for a lot of different reasons, and there's a lot of conversations about whether this is ethical or not. But the idea is that, so go to the marketplace. If you're going to spend $7,000 to max out your deductible and pay your premium, more like probably $8,000 in a year, why not pay that, $5,000 of that $8,000 to a clinic? So this is your direct contract with a clinic or a provider. That clinic and that provider provide all of your care. It involves, all the contracts are slightly different. This is taken off a lot more on the East Coast and other places where there is accumulated wealth. For obvious reasons, because you're paying upfront cash to these people, but you get discounted rates on medications, which providers can order for much less money than people can purchase them even with insurance. Providers can offer different cost labs. So, for instance, a CBC might cost me $1.25 as a provider, but if it gets billed to insurance, it might be $24. There's easily, hundreds to thousands of percents markups on a lot of these things in terms of when they get billed to insurance. So it's one of the ways to also drive down healthcare costs. And then providers can provide all those labs, medications, definitely, routine care and also minor surgery and acute care in office, and everything that is truly emergent care, like, you're bleeding from the head, go to the emergency room, and that's covered by our government, is one of the thoughts, or from, a catastrophic plan that we pay for. In the system, pre-existing conditions would be irrelevant. You come in exactly as you are, and your healthcare, you, the person, are managed, rather than whether or not an insurance company will pay for that or not, or whether or not it's coded properly, or whether or not the bill was submitted properly. It takes out all of that administrative stuff, boom, right off the bat. No prior authorizations, nothing. You want the care, you pay for it, you get it. And we can make the argument that it's super inequitable, and possibly for that reason also unethical. And the other thing we can think of is like, well, if we're also making people pay for healthcare, like, I'll come back to my, ongoing example of people between the coasts who may be hours away from a provider, and they're forced to buy a healthcare plan that they can neither use nor really afford. Why not actually allow them to choose the doctor they want, maintain the continuity of care, construct their own contractual agreement, and pay for it? There's some major, potentially, like some equity issues, like that assumes that people have money up front to pay for that kind of stuff. Obviously, there's lots of other financial planning that can go into that scenario. But what are the other possibilities that are positive and that we know from the literature actually have positive impacts on people's health, like the ability of less miscommunication, the ability to have more direct communication with your provider, the ability to have more time with your provider, because when providers don't have to channel, 35, 40 people through in a day just to keep the business running, they can spend more time with you. You have more time to build a relationship and possibly make less mistakes. There can be a lot more price transparencies and at-cost healthcare. It allows clinics and healthcare to remain more innovative and nimble because it's smaller and less burdensome. Potentially less inefficiencies. I love this one particular example from the literature, that it takes 32 clicks just to chart a flu shot in an EMR. And I'm like, I would not disagree with that. There's some possibility that if you take healthcare out of a system, that maybe it would be less rigorous, that maybe it would be less evidence-based. But what they actually find is that people who tend to run their own shows, and their reputation, their quality of care, that value-based care is really their calling card, you do actually find that they tend to adhere much more to evidence-based practices and more rigor and more innovation in their practice. And you'll definitely see higher provider sustainability if you don't have to deal with insurance companies. Pretty sure all of my colleagues can vouch for that. So these are just to, give you a couple other things to think about as it pertains to healthcare, and introducing the whole healthcare system, which is ultimately the goal of this class is really to be like, this is our giant, not so nimble, incredibly challenging to understand healthcare system. And here are some of the things for you guys to be aware of in terms of being able to advocate to patients. Like, I know that you may not understand this, neither does anybody else. But let me give you some ideas. There are some ways to think around the system, that maybe the way that we are trying to reform the system might not necessarily be our next best move. I don't know that necessarily direct primary care is, but where it is showing up, it's actually been shown to be fairly successful. So it'll be interesting to see what happens over the next couple years and how some of these practices fare. And also to see what happens to the marketplace, and if and when it does actually go away related to issues pertaining to constitutionality. It'll be interesting to see who picks up the slack in that. So I am going to pause this in one moment. Cool. So we're done with the slides. There is another article on this week's material, or this week's modules, about just thinking about what happens when we take away the tax penalty. So some of the stuff we've talked about in class, but I thought the article would be interesting for you guys to read. It's pretty short, and it just talks about the financial discrepancies that are likely to occur now that this tax penalty has gone away. Let's see. There are a couple things that came up. Oh, thank you guys for filling out the survey. It was super helpful. I love getting the feedback. There's a couple of amusing comments in there too, so thank you for those. There was a couple questions that came up about PowerPoints. They're up every week under the module, so please do take a look at those and look back on them and let me know if there's any confusion in any of the material presented. All right, I think that I'm all complete with this. Hope you enjoyed it. If you have any more questions, let me know. Enjoy the